Hi guys, this is Dr. Ramesh Krishnan, and this lecture video is about jugular venous pulsation and its clinical correlates. The content of my lecture include mechanism of jugular venous pulsations, how the different waveforms are produced, and how these waveforms get altered in different clinical conditions. So guys, firstly, during cardiac cycle, there is right atrial contraction. This contraction of the right atrium leads to retrograde flow of blood into superior vena cava and jugular vein, and as a result of which a wave of the JVP is produced. So, a wave of the JVP is produced because of right atrial contraction, and this A wave occurs during diastole of the cardiac cycle, but during right atrial systole. A wave of the JVP follows P wave of the ECG and synchronizes with the first heart shot. We will study about the different abnormalities of A waves like prominent A waves, canon A waves, or absent A waves in the subsequent lecture. Now, after the production of A waves of the JVP, right atria relaxes. And due to a relaxation of the right atrium, X descent is produced in the JVP. This X descent occurs during systole of the cardiac cycle. However, the X descent is interrupted by a positive wave that is called as C waves. How these C waves are produced? These C waves are produced because of the closure of the tricuspid valves. When the tricuspid valve closes, then there is upward bulge of the tricuspid valve, and this leads to the production of C waves in the JVP waveforms. And these events occurs during isovolumic contractions of the cardiac cycle. X descent below C wave is X prime descent. Now this X descent occurs because of decreased right atrial pressure, descent of the floor of the right atrium, and downward pull of the tricuspid valve by contracting right ventricle. Because of these events, X descent is produced in the JVP. That is, X descent is produced because of decreased right atrial pressure, descent of the floor of the right atrium, and downward pull of the tricuspid valve by contracting right ventricle. This X descent begins during systole and ends before S2. We will study about the abnormalities of the X descents like prominent X descents and absent X descent in the subsequent lecture. Now, after the X descent, the tricuspid valve, which was open, closes, and as a result of the closure of the tricuspid valve, V wave of the JVP is produced. This V wave of the JVP is produced because of continued right atrial filling in a closed tricuspid valve, and this event occurs during systole of the cardiac cycle. This V wave, which is the positive wave in the JVP, peak after S2 and synchronizes with the carotid upper stroke. This V waves occurs during isovolumic relaxation phase of the cardiac cycle, and we will study about different abnormalities of the V waves like diminished V waves, prominent V waves with the prominent A waves in the subsequent lecture. After the production of V wave of the JVP, the tricuspid valve which was closed opens, and these events occurs during diastole of the cardiac cycle. You must notice that V wave was produced during systole of the cardiac cycle. Thus, when the tricuspid valve opens, then right atria starts emptying and right ventricle starts filling. As a result of emptying of the right atrium, Y descent in the JVP is produced. And this Y descent occurs during diastole of the cardiac cycle. In the early phase of the diastole, there is rapid filling, and during the diastoles, this Y descent begins and ends after S2. So, this Y descent was because of right atrial emptying and right ventricular filling, which occurs during diastole of the cardiac cycle. Continued diastolic inflow of blood to the right side of the heart leads to ascending limb of the biwaves. So, these biwaves have descending limb and the ascending limb. Ascending limb is because of the continued right ventricular filling during the diastole. We will study about the abnormalities of the Y descent, like slow Y descent or rapid Y descent, in the subsequent lecture. Following the production of the Y descent, a period of diastasis is seen in the cardiac cycle. During the diastasis phase, the right atria and right ventricles are in continuation phase. That is, right atria, the blood from right atria is entering into the right ventricle. Thus, during the diastasis phase, when the diastole is long and heart rate is slow, there is decreased filling of the right ventricles in these cases, and a H wave can be produced. These H waves are small and brief waves. Following the production of the H wave, A waves appears in the JVP. This may not be seen in some cases. Now come to the initial slide. We have seen that the A wave of the JVP is produced because of right atrial contraction. we can see these waveforms. This is the normal waveforms of the JVP. This is the A waves, which is followed by X descent. X descent is interrupted by a positive wave, that is called C waves. Below the C wave is the X prime descent, and then comes the V wave, which is due to right atrial filling. Following V wave is the Y descent. Then comes H waves, which is seen in the diastasis phase when there is decreased emptying of the right ventricle. And following H wave is the A waves. Thus, this from X to V waves occurs during systole of the cardiac cycle, whereas A waves and Y waves occurs during diastole of the cardiac cycle. Now let's discuss about the different abnormalities of the A waves, which can be seen in the different clinical conditions. A wave can have abnormalities in the form of prominent A waves. This prominent A wave is seen in tricuspid stenosis, right atrial myxoma, tricuspid atrasia, pulmonary stenosis, pulmonary hypertension associated with mitral stenosis, acute pulmonary embolisms, severe aortic stenosis, or hypertrophic cardiomyopathy. In these cases, prominent A wave is seen. We can notice the waveforms. Here we have the prominent A waves in the JVP. Then the canon A waves. Canon A waves can be regular canon A waves or irregular canon A waves. Regular canon A waves is seen in AVNRT, atrioventricular reentrant tachycardia, that is retrograde conductions defect, isoarrhythmic AV dissociations, ventricular tachycardia, whereas irregular canon A waves are seen in complete heart blocks, ventricular pacings, and ventricular ectopics. Then here comes that how will you differentiate giant A waves from canon A waves? Giant A waves are uniform in height, whereas canon A waves are not uniform in height. These canon A waves are observed during each of the cardiac cycles. They can be seen in every cardiac cycle, whereas these canon A waves are intermittent. Sometimes they may not be noticed in a particular cardiac cycle. They are sporadic. Then let's discuss about the absent A waves. Absent A wave is seen in atrial fibrillations or sinus tachycardia. You can see here, this is the waveform of the absent A waves. Here, after this is the X descent, and above it we cannot see any A waves of the JVP. This is the waveforms of the canon A waves. In the canon A waves, the A waves appears like a canon, which is seen in these different clinical conditions. Another fact about atrial fibrillation is that not only in atrial fibrillation there is absent A waves, but in ECG we cannot notice any P waves. Apart from it, fourth heart sound is also absent, and these atrial fibrillations are most common arrhythmia in clinical practice. So we have discussed about A waves, how these are produced, what are the different abnormalities of the A waves, And let's discuss about X descent. We have seen that the X descent is because of right atrial relaxation. We have seen that the right atria relaxes, as a result of which X descent is produced. This X descent can have abnormalities in the form of absent X descent or prominent X descent. Absent X descent is seen in tricuspid regurgitations, whereas prominent X descent is seen in cardiac tamponade, constructive pericarditis, or right ventricular preloads, as it is seen in ASD, atrial septal defect. Here you can see these waveforms of the absent A waves in the tricuspid regurgitation. Here is the A waves of the JVP. After A waves, there is no X descent, which is followed by a positive V waves and then Y descent. Thus, this is the waveform of the tricuspid regurgitation, in which there is no X descent. But these tricuspid regurgitations have prominent Y waves with absent X descents with CV waveforms. On the basis of these CV waveforms, the severity of the tricuspid regurgitation is assessed. This is the waveform of the prominent Y waves, which is seen in cardiac tamponade, constructive pericarditis, and right ventricular overload conditions like atrial septal defect. Here we can see that this is the A waves, which is followed by X descent, and then this is the V waves, which is followed by Y descent. Here these conditions have prominent X and Y descent, which is seen in cardiac tamponade, constructive pericarditis, and right ventricular overload conditions. Another fact about X descent is the blunt X descent, which is seen in atrial fibrillations and right atrial ischemia. In these cases, X descent is blunted. After X descent, we have a positive wave that is called as V waves, and V wave is because of right atrial filling during isovolumic relaxation phase and in the systole of the cardiac cycle. These V waves can have abnormalities in the form of diminished V waves, prominent V waves without tricuspid regurgitation, or prominent V waves with prominent A waves. This diminished V waves is seen in cases of hypovolemia or in ventricular venodilators, the patient which is treated with venodilators like nitrates. Prominent V waves are seen in tricuspid regurgitations. Prominent V waves without tricuspid regurgitations are seen in large ASD, VSD, severe congestive heart failure, or in the cases of atrial fibrillations. Here we can see the prominence of the V waves in the JVP. This is the waveforms of the prominent V waves with the prominent A waves, which is seen in non-restrictive ASD, constructive pericarditis, or right ventricular failures. Here we can see the prominence of the A waves and the V waves of the JVP. Another fact about tricuspid regurgitation is that the prominence of the CV waves is called as Lanzi sign. So, the right descent of the JVP is produced because of right atrial emptying and right ventricular filling. Initially, there is Y descent. However, in the later phase, there is ascending limb of the Y waves. Why there is initially Y descent? It is because of rapid right ventricular filling. Whereas in later phase of the diastole, there is continued diastolic inflow of blood to the right side of the heart. And it is because of which there is ascending limb of the Y waves. And this Y descents occurs during diastole, which begins and ends after S2, heart sound. The abnormalities of the Y waves, Y descents are slow Y descent and rapid Y descents. Slow Y descent is seen in tricuspid stenosis, right atrial myxoma and cardiac tamponade. These are forms of the slow Y descents. In these conditions, slow Y descent is seen, and thus here you can notice a slow Y waves, slow Y descents. Whereas rapid Y descent is seen in severe tricuspid regurgitations, constructive pericarditis, severe right ventricular failure, AST with mitral regurgitation. Here you can see the rapid Y descents in the JVP. In the constructive pericarditis, we have prominent X and Y descent, but the constructive pericarditis has Y descent being greater than X descent, and this is called as Friedreich sign. We have earlier studied that tricuspid regurgitations has CV waves, and on the basis of these CV waves, we assess the severity of tricuspid regurgitations. Here, after C waves being prominent, and this is the V waves. These waveforms get altered with the severity of tricuspid regurgitations. An interesting fact about cardiac tamponade is that in cardiac tamponade, there is decreased filling of the ventricle. As a result of these decreased filling of the ventricle, there is decreased stroke volume, decreased cardiac output and decreased blood pressure. And this condition is called as obstructive shock, which is seen in cardiac tamponade. Following H waves, following Y descent, we have seen that there is H waves of the JVP, which may not noticed in certain conditions, in all conditions, and this is seen during the diastasis phase when the diastole is long and heart rate is slow. This H wave is because of decreased right ventricular fillings. So we have studied about various waveforms of the JVP. And to remember these waveforms of the JVP, we have the mnemonics that A waves of the JVP can be remembered with atrial contractions. With both A waves and atrial contractions have A letter as the common. C waves of the JVP can be remembered with tricuspid valve closures. Here we can see closures contain C as the letter. X descents in the JVP can be remembered with atrial relaxations. X is the common letter in the relaxation, and V waves can be remembered with venous filling. Here V is the common letter between the two. Y descent can be remembered with emptying of the right atrium into the right ventricle. Thus E in emptying we have the Y as the common letter. So we can remember the mechanism of generations of the different waveforms of the JVP with these mnemonics. So guys, this was all about jugular venous pulsation and its clinical correlates. I will be posting more videos related to clinical aspects, which is the grave area of the medicines. So do keep in touch with us